Okay, sorry. Someone has raised a question. Yes, let's have it. Okay, can you combine omalizumab together with Dupixent in a patient with atopic dermatitis and CSU, Ravi?
So it depends on which is the dominant reason. I have a few patients with overlap when they have CSU and atopic dermatitis. So some patients are excluded on omalizumab and some patients are excluded on I know that before. So when I have these questions, I basically ask the experts so basically they're teaching from the experts what is your dominant lesion in this patient? Is it your eczematous lesion or is it the active lesion? So you choose your biology based on that. If you ask practical feasibility, like we do it all the time. We have patients with atopic disease and rheumatoid, and they have so there's no contraindication for two biologics in one patient as long as you look at all the markers and the timing and safety things are good. But in one patient, can you do omalizumab or Dupixent if you want to? Yes. But if the practically doctor goes to, I guess you need to go very long. That's not next to the problem. Because I was under the impression that I could do both, but what the expert said is do in the dominant lesion.
Okay. Okay. So the short answer to this question is no. There's no recommendation, but there's no contraindication. However, if you look at the how the mechanism of action of Dupi, it actually reduces IgE production. So you're given an anti-IgE, but we know we have Dupi, who is an anti-IgE, if you like, indirectly. So why would you use it? And I think until we have evidence, I think it doesn't make sense to me that to use Dupi and omalizumab in the same patient does not make sense to me personally. But if the question, can we use two biologics in one patient, for example, if a patient has rheumatoid arthritis and they're on a Humira, but they have now chronic urticaria and we need to use omalizumab, I think there is a case to be done there and or to be made for using the two biologics, because both work on two different limbs. But I think we have rheumatology and rheumatologists and gastroenterologists are far braver than us because they've been using biologics for over 25 years or so, and they have more experience in using more than one biologic in the same patient. So for us, we're still learning, I think, and we have to be very careful and cautious as well. Okay, Ravi, do you have any comments? Okay, so I'll move to my second presentation, and this is a small study that we've carried out in Cleveland Clinic, Abu Dhabi, looking at the efficacy and safety of omalizumab in chronic spontaneous urticaria. So I'm going to share our local experience with you here. Okay, so as I said earlier, we're Center of Reference and Excellence of Urticaria, or UCARE, since March 2020. We're in fact the first center to be accredited by Galen as an Urticaria center, and they came and we have to answer a number of questions. So it's an audit type thing, and we've been approved as a center of excellence. Now we have about 350 patients on omalizumab, and these patients, they mostly get the omalizumab for urticaria, and we use different doses as I said earlier, so from 300 to 600 milligrams, and we use the frequency of 2 to 4, 6, 8, and 12 weeks. So we carry the study because we see a lot of patients with urticaria. As I said earlier, we see about between our urticaria exposure of the total patient we see is about 13 to 17% of patients we see in our clinics are due to urticaria. So we said, why not we look at this group and find out what's happening with this, or take a sample and assess it. So we took this sample to assess the effectiveness of omalizumab in treatment and control of chronic spontaneous urticaria, and to try and identify patients who developed actually adverse effects of long-term treatment. So this was a retrospective study carried out by a lovely lady who was doing an attachment with us in the department. And we looked at our patients between September 2015 to September 2018. And this study was approved by the Hospital Research and Ethics Committee. So the sample was about 79 patients, and these patients have a definite diagnosis of chronic spontaneous urticaria. They're all above the age of 40 years of age, mixed males and females, and they have the disease for more than 6 months. And these patients had a refractory CSU, so they're not responding to the treatment, and they're all on omalizumab. So what we did, we assessed them using different tools. So we've used, this is the urticaria control test that I was telling you about. Right. So this is the urticaria control test that I was telling you about, and this is what we've assessed them with, and these are the limited blood tests that we've done. And then what we did was we stratified the patients into 3 groups. And the stratification was based on the response to omalizumab and according to the urticaria control test. So we've divided them into complete responders, partial responders, and poor responders. The complete responders, we identified them as those with high UCT scores, more than 12, who stopped or reduced their antihistamines, and who would complete symptomatic improvement after 1 to 2 doses of omalizumab. Partial responders, the UTK score is less than 12, continued on antihistamines and felt better after the 2nd dose of omalizumab, and the poor responders had low scores, continued on high-dose antihistamines, and needed more than 4 doses of omalizumab to get a response. So the results were very interesting. So most of our patients on all the 3 groups were females, and the interesting thing that the vitamin D deficiency was really noted in a significant number of them. A lot of them had raised total IgE, and a substantial number of them had also thyroid antibodies. The results are, and again, based on the patient stratifications, we found that 63 or 70, about 80% of them were complete responders. And these patients responded, as I said, to the 1st or 2nd dose of omalizumab, and the UCT was more than or equal to 12, reduced antihistamines or stopped it completely, and they had, as I said, 1 or 2 doses of omalizumab. Now, the partial responders, on the other hand, their UCT score was 5 to 11. There was no change in their antihistamine use, and they responded to more than 2 doses of omalizumab, and this group accounted for about 10%. The other group, the poor responders, then the number in the poor responders wasn't really high, but as you can see there, they all had a UCT score of less than 5, no change in their antihistamines. They continued to take high-dose antihistamines, and they needed a number of doses to control is more than 4 doses, and this is only constituted about 2%. So you can see the majority of complete responders, 80%, responded from the 1st or the 2nd dose of omalizumab. Now, again, this slide summarizes the results. So we have about 57% of our patients were females, like being published in the literature. Thyroid autoimmunity, Ravi showed that it's about 30% in our patient group, we're about 20%. Look at vitamin D deficiency. Vitamin D deficiency was, quite high in our cohort, about nearly half of them that had vitamin D deficiency, and we needed to correct that, of course. Now, after the first dose of omalizumab, about 44% of complete responders achieved full score of the UCT, that's 16. About 42% have reduced or stopped their antihistamines completely. Now, only 10% of the partial responders have been able to reduce but not stop their antihistamines. Now, the other interesting bit here, which was shared with Charity and Marcus Moore, that about half of the complete responders and about 60% of the partial responders had high level of total IG before starting omalizumab. So what we implied from this result that maybe, and this is a maybe, and it has been shown by Marcus Moore actually, that maybe high IgE can be used as a surrogate marker to identify patients who might respond to omalizumab. But again, we need more evidence of that. But this is what we show, and this is in concordance with Marcus Moore group, which will published a small study on this. Now, safety concerns. The duration of therapy with omalizumab was about 11 to 38 months, about 11 months mean. All patients study tolerated the 300 milligrams very well, no issues at all, and there was no significant adverse effects that needed us to stop the treatment. So our study is the first actually in the MENA region. There are no studies, if you look at the literature, there are no studies looking at the efficacy and safety of omalizumab in CSU. And so this is really a landmark. We haven't managed to publish it, but I didn't have the time to sit down and publish it. I think it's really an important piece of information that we need to get out. And the other conclusion is that omalizumab is very effective and safe in controlling chronic spontaneous urticaria after the first dose in more than 40% of patients. And that maybe, and again, this is a maybe, that raised IG may be useful surrogate marker to predict omalizumab response.